Hey guys, we are here. Well, I'm here with Miss Christine Hall. Welcome to the show, Christine.
Hi, thank you so much, Jennifer. I am thrilled to be here.
Well, the question comes up, Christine, and maybe you've had this question from your parents when you were a kid. When are you gonna learn? So it came to me, like I've heard that from my parents before. When are you gonna learn, girl? And I feel like it's an ever-changing question that we see in healthcare. We're constantly learning, right? But then there are certain things we should probably know better by now, right?
So I've been told a lot. At this point in my life, my husband says, I don't want to be right. I just don't want you to do it. Oh,
Exactly.
okay.
Yeah. We have those things too. So I thought we'd take a few minutes today. It's short and sweet live we're going to do here on LinkedIn and Facebook and our YouTube channel. So we hope you can listen wherever you're at and interact with us today. So we're looking forward to that. So it's hard to adapt to change, as we know. And we've heard the old adage, I've always done it this way.
Oh my gosh, Jennifer, that is probably one of my biggest pet peeve statements. Like it makes the hair on the back of my neck kind of stand up. Um, because nothing is the same as we used to do it. My car isn't the same as it used to be, the cars I've had in the past. My computer, Lexi and I were just talking recently about computers and the technology that they have now. So nothing is the same.
Not at all. And so I wanted to highlight to all of our audience out there, if you're a physician, a practice manager, a coder, a biller, auditor, whatever you're doing in healthcare, do you oppose change, or are you willing to explore new ways of doing things? And I've worked in the hospital setting before. Actually, the majority of my career, I've worked for facilities in a facility setting, whether it's for the physician office or working directly with the clinicians. And things change every year. I mean, we are in healthcare. We should be expecting things. We should be expecting things to change. So it shouldn't be surprised when we get changes like our quarterly and annual updates.
Well, I was going to say, Jennifer, you worked more on the facility side. I have always worked more in the pro fee side, and one of the things I think that I never stop getting enough of is when we go in to do an initial review of the practice, and I say, well, this policy has changed, or here's a new service that technically you're doing, but virtual check-ins, right? Those types of things. And providers ask me questions like, when did that take place? You've been losing revenue for a while, my friend. That's why it is so important, like you said, to really be on top of those quarterly and more so the annual changes that come out.
Absolutely. And I had the other day talked to someone, and there was a modifier that we kind of all know about because we read the final rule when it came out, and we are always reading and keeping updated. I didn't know that this modifier was real, and neither did anyone at their facility. And that is a question for your supervisors, because those are the ones that are supposed to be keeping up to date. If you have corporate educators, they should be sending out regular updates to things. At our facility, we had a corporate education department, and it was great. Like, they would send out reminders, and we'd have our monthly webinars on certain topics, but they would send out email blasts to say, hey, this is new, make sure your departments know about this. And maybe they only send it to maybe a supervisor or an administrator, but as an administrator and a supervisor, isn't it your job to make sure your team is well informed? What are you doing all day? Are you just going to meetings all day and not expressing to your team what you're learning and how it affects them?
Well, Jennifer, I see it also from the other side, from the smaller physician practice, where you have an office manager who has 7, 10 hats. And how do they keep up with all of this? So my recommendation is you need to reach out to people like myself and to Jennifer and to our colleagues that, we are the subject matter experts. Our job is to be on top of that. So have a good outsourced compliance support that provides you with those emails, provides you with that additional education. I probably email my clients at least 2 or 3 times a week. Hey guys, did you hear this? United Healthcare is now requiring more pre-authorizations, and here are some of the services that we provide in our practices. So if you yourself don't feel that you're a large enough organization that you can have that dedicated in-house education or in-house support, then make sure that you've got some sort of external support, because at the end of the day, it is our responsibility to know that information.
It is. If we're not accountable to our own knowledge, we're definitely accountable to those that we are over. And if you're an employee, maybe you don't think of yourself just an employee. You are a professional, but you are employed by a facility, right, or an office, and so you are an employed situation. So you do have to follow a certain chain of command, but it doesn't mean that you just follow blindly. You're a professional. You have a certification potentially, right? And you are, of course, accountable to uphold that credential. And so we look at the idea of repetitive mistakes. Now, we're imperfect. No one in this world can stand up and say, I'm a perfect person. There's just, some try, but
I'm not going to be there. I'm going to tell you now, I'm not going to be there. I'm not a perfect person at all. I make mistakes just like anybody else does. And I just hope that I'm doing the right thing. But I think, Jennifer, you and I know that there are resources out there that not only do we hope we're doing the right thing, but they're also monitoring us to make sure we're doing the right thing. So whether you're, again, in a big facility where maybe you have a compliance committee, a compliance officer, compliance meetings, or you're a small individual group that maybe you have to outsource that compliance assistance, you always want somebody that can come in and objectively look at the situation and tell you you're doing a good job, or you're making mistakes, and here's how we fix those things.
Exactly. And, at Healthcare Inspired, a lot of I've been talking a lot about data and auditing lately. And Christine, you're at Sterling Global Solutions. You also are an auditor for many specialties. What I wanted to let everyone know is it doesn't always come down to an audit. Sometimes we can dig into your information, your data, and we can give you some insight into where your risks are. We don't necessarily have to dig into each chart. You send us a report, we can tell you right away where your problems are.
I like to call it a review. We're just reviewing what you've got going on to identify opportunities
For improvement. Yes. And when we educate physicians, we don't go into the room and say, hey, you did this wrong, stop it. Like, you don't tell them that. They hear enough bad news, they have to give bad news. We don't want to tell physicians they're wrong. We want to help them feel like, okay, maybe they weren't aware of this guideline because they're busy seeing patients. They don't have time to read the final rule, and they don't have time to read LCD policies and all that. That's what our job is. So I am a little tired. I'm going to get on my soapbox here. I'm a little tired every time I get a call for education and the hospital says, oh, our physicians are doing the coding. These poor physicians. And I feel so bad for them because they don't have time for it. Maybe it's a cost issue. Maybe they think they can save more money by eliminating the front end coding work and do on the back end. AI software is out there, which has a great potential to help alleviate some service lines, but not all of them. They require a human brain to do some thinking.
But Jennifer, one of the things that I've observed is medical school doesn't teach the business of medicine. And I want my doctor to really be focusing on how to take care of me. But I think that our providers need to realize that they need good, supportive, administrative people, coders. We didn't become coders overnight. I think it's almost a little bit naive to think that physicians, amongst all the things that they've got to understand about treating patients, or providers in general, I think it's a little naive to think that they also need to understand all the intricacies that go into coding and billing and reimbursement and the business of medicine. Because again, we didn't learn that overnight, and that's not part of their core education. And frankly, I don't want my doc thinking about, is this a 214 or 215? I want my doc thinking about, what's wrong with Christine? Right?
Exactly. I know, right? I mean, you think about the level of detail that physicians are trying to put in the notes because they know that they need to be improving their documentation. And I've talked to so many of them, and they're like, "How much do I put in? I mean, what's too much? What's too little?" And I want to get them to stop thinking that way. Just think about your patient. As an example, let's think about a patient with diabetes, for instance. Christine, what are common required elements or important elements for a patient with diabetes? Let's keep it simple. What would you want to see in a note?
So just give me that patient's perspective, first of all, of how they think it's going. What is the patient experiencing? Are they having increased thirst? Are they having hypoglycemic episodes? Are they monitoring at home? What can that patient tell me that is important to know about diabetes? Then I want the doctor to do their doctoring, right? I want them to feel the thyroid. I want them to do a blood sugar in the office. I want them to check the patient's extremities for any signs of neuropathy. And then I want them to analyze all of that information, and just that information, because that's what the patient's here for. And I want them to make a decision. Do they need to continue this plan of care? Do they need to change this plan of care? Order a new med, refer them out, order a test, and tell me when you want to see them back again. When is that mission accomplished expected to be? That's it. That's all I need out of a note. And that note, let me code it for you. Let me tell you exactly what that note means, right?
Yes, and we use the term education, and sometimes that can become a negative word. We can use the word training, we can use the word learning, but let's just use the word growth because we're all trying to grow, whether it's revenue or in our careers and our knowledge. Knowledge is the word. Physicians get all the knowledge upgrades, I could say, that they want because the hospital pays for them to have upgrades in knowledge. And of course, sometimes they pay for their own upgrades in knowledge, as I say, but coders and billers and even practice managers, they need upgrades in knowledge. And of course, those of you out there who are practice administrators, managers, we do encourage you to think about attending our upcoming virtual practice management conference. It's coming up on October 5th. Both Christine and I will be speaking at that event, and we encourage you to attend. You can go to healthcareinspiredllc.com and purchase tickets to that. There are CEUs for those of you who have a practice manager credential, and also coders that are interested in becoming practice managers or interested in leadership. We encourage you to attend that. But on top of all that, there's so much room for growth and developing a culture of learning in our organizations, where it's not discouraged. It's not a budget issue. It's, I have worked on budgets before for organizations. I have my own budget as the director of education for a previous company. So I understand there's a budget issue, but there's also elements of things that are necessary that your budget eats it because you have to have it, like compliance. Do you think that having a compliance department is not worth it? And so you say, oh, we're going to scrap a department this year because we can't afford
even
it.
think about that.
I mean, it's no
Compliance is
different.
the foundation of any practice. Compliance, I think we get kind of hung up in the word compliance. I think maybe we should think about another word for compliance would be assurance. That's what we're doing. We're assuring that we're doing the right thing, that we're capturing all of the opportunities that we have available to us, that we're finding that fine balance between the providers with their growth opportunities, that we're looking at the practice in general. I mean, practice managers have so much on their plates that they have to constantly have their fingers on. And I think that compliance helps assure that nothing's falling through the cracks. It's that foundation.
Exactly. And, we talk a lot about CDI, and, I'm going to shout out to our upcoming conference coming up September 14th and 15th. The CDI Awareness Conference is coming. And so I wanted to let everyone know some great stuff about that. It is going to be on September 14th and 15th. CDI, clinical documentation improvement, is, of course, becoming more popular in the outpatient setting. Those of you who work with inpatient, it's been a thing forever. You've had that constant back and forth between the coders, the physicians, those queries. So we're going to talk about inpatient CDI at the conference, but we're really going to hone into on the outpatient compliance, documentation, what CDI looks like for a pro fee setting.
Right.
And it's really important. We're going to dig into 3 major areas of documentation, 3 major specialties. We're going to dig into pulmonology, cardiology, orthopedics. Oh, I forgot GI. We're going to talk about GI too. So some major areas of chronic conditions that we see and documentation improvement that needs to be there. I mean, GI too, but it's like there's no guidelines for
Well,
it.
the other thing I was you kind of skirted right there at the end, and I wanted to circle back to it.
Sure, absolutely.
One thing that is really important with CDI, as we're seeing that next year, we're going to have a lot of changes in the value-based reimbursement.
Yes.
And we've seen even in the past, historically, recent history, that one of the major downfalls of value-based reimbursement is the lack of CDI, is the lack of support, the lack of documentation. And that's really causing a problem. And with the forecast of the changes that are happening in value-based reimbursement, having that good grip on CDI from that outpatient pro fee side, or used to be pro fee side, right? Now we're value-based side, but having that good CDI, trust me, friends, with the changes that are coming up, it is absolutely pivotal that you have a good grasp on CDI moving into the next year.
Yes. You have to have it. I use this example all the time, like a broken record. I mean, if you've heard me talk about it, you have a patient who they have HPI, you're talking to them, they're telling you their story, the history of why they are there. You get down to the review of systems, you're going to review the systems, you're looking at the exam, and you're looking at a certain organ system that is completely normal. No, nothing wrong with it. Everything's normal. And then all of a sudden, you get down to the assessment and plan, and they have hepatic encephalopathy that's severe and it's worsening. Okay,
I call
how
it a
do you know
surprise
that?
diagnosis.
Yes, it's funny, right?
Surprise! You never
There
saw it
it
coming. Yeah.
is. Yeah, that's what it's like, right? So we want to eliminate that. Now, I
My
also had the
next
chance.
question is,
Yep,
Jennifer, when you see the surprise diagnosis, I always have to go, well, what are we doing about it?
exactly.
Because that is truly the reason. Imagine if you go to the doctor's office and the doctor says to you, today's visit is going to be $1,000. Okay, not that I would smirk at that. I would, of course, but I would say, okay, but what's wrong with me? Oh, Christine, you have diabetes. Well, what are you doing about it? Because that's why I'm here. Otherwise, I don't feel like I need to pay you $5 or $1,000. And the payers are the exact same way. They feel the same way. So while providers sometimes get frustrated with all of the requirements or the things that they feel need to be in that note, we just have to remind providers that when you're trying to use that documentation to equal a reimbursement, payers always want to see not only what's wrong, but what are you doing about it? Because that is what really motivates them to pay you more or less. What are you doing about it?
I
Right?
love it, Christine. Like, it's like, when are we going to learn? The title of our presentation today. When are we going to learn that these things aren't going away, regardless of what payment model we go to? We still have to show the quality care has been given to a patient. How do we do that? Documentation is always going to be the driving force. It always has been. You have to have a legal document, a record of what you did for that patient, because how is the next physician going to know what's going on with them? Primary care physicians documenting the GFR for chronic kidney disease and the levels, right? And then that's going to give information to maybe the next physician. Okay, this is their level here. It progressed slowly over time. They have all these records now to see the progression. And so when they get to that specialist, they're going to say, okay, they have hypertension. They've had it this long. They have heart disease. They have this heart failure now that's appeared. It's progressed to heart failure. They also have chronic kidney disease. What stage are they at
Mm-hmm.
based on the GFR? The list goes on. And I mean,
Well, I
we could
mean,
talk all day about it.
but we can tell providers, a lot of providers really do know their patients. I'm pretty impressed with it. I mean, I know my
Yeah.
primary care doctor, I feel like she knows everything about me.
Yeah.
But if tomorrow she hits the winning lottery numbers and decides to go buy an island somewhere and retire, the next doctor that's coming in, I still need to be treated. I still need care. How is that next doctor going to treat me? Or does that doctor, are they going to need to start all over again as a patient? No, no, I don't want to
Yeah.
start all over again. I want that documentation to carry me on to the next provider thoroughly so that we don't need to, put me through more testing, put me through more radiation for imaging, put me through more invasive testing that I've already gone through and identified a problem. And so that, and then, so I get when providers say, I know my patients. But again, what if you win the lotto and you need to buy an island? How am I going to get taken care of?
Exactly. And Christine, haven't you heard of documentation by osmosis? It just comes, right? I mean, haven't
Well,
you heard of
no,
that?
no, but I do hear a lot, every doctor knows what I mean when I say this. Not every doctor does. And
No.
even more so, when we get involved, we're really talking about from the reimbursement side of life. And reimbursement, unfortunately, there's no doctors out there processing claims for a living. Nobody goes to med school for 8, 10, 12 years and says, you know what, instead of brain surgery, I think I want to process claims for Aetna. I've never heard that in my life, right?
Yeah.
Um, so there's administrative people that are processing claims, and that's why providers need to tell the payers, right, what actually went on, what's
Mhm.
happening, why are we going to get paid, what did you do
I
that
love
makes me
it.
want to pay you more money?
Christine, your passion is so like infectious. I love it. And I was thinking about, and I've told this story. I think I told this story on LinkedIn, but I didn't tell it live. So back in May, when I got back from my family trip, I was having a medical, I thought an emergency. So it was painful, and I went to the urgent care. This urgent care physician, I was also having like cold symptoms, but I had a
Oh,
mass also. And so I went to the nurse practitioner that was there, and she documented everything. I get my little printout, right? And nothing about the major pain that I had experienced. She just documented the cold symptoms and the fact that she tested me for COVID and for strep. And that was it. And then later that night, I had to go to the ER because it was so severe. And that physician, of course, it's all the same hospital system. So they're going to be able to have access to their urgent care records too. So they pulled it and they didn't see it.
why didn't you mention it when you were here earlier, Jennifer?
I don't know. I mean, I did, but you just didn't document it. And now you have missed a diagnosis or something else you could have seen from the day before, progression of symptoms that not only tells you how to take care of your patient, but also helps you get that extra revenue because of the
Doesn't sound like they
increased
did a whole
symptoms.
lot for you that day.
Probably not. No. I mean, yeah, I could have probably dealt with some of the cold symptoms at home. I did want to know if I had COVID. That was a good thing to go in for, but I could have gotten a test for that. But anyway, it just the list goes on of missing elements that are relevant from one physician to the next. The next physician was great. I mean, he just really, put it all together, and he did testing, and he wasn't just going to be satisfied with my word. He was going to figure it
That's
out, right?
that's a really good insight, Jennifer. And we need to remember that while in my world, I choose to see the good in everybody. I choose to see the opportunity. But unfortunately, we know that as my friend Betty Hovey posts every week, she has the Friday Fraudsters that
Yeah.
she posts. We don't always have the best actors.
Mm-mm.
And so we know that even in any profession, you're going to have those people in those professions that are passionate, and
Yeah.
you're going to have those people in the professions that they're just trying to get by day. Um, and
Yeah.
and so really it needs those external people like you, like myself, like our colleagues, like the practice administrators, the practice managers, the department heads to work together to kind of support those providers or anybody in whatever role that maybe are not feeling their best, that could be making better choices, right? That could be soaring higher, right? So it does. It takes a village almost to make these things happen.
It does. And, I am not knocking any practice managers that have manager experience. They have their MBA, Masters of Business Administration. You have those who have their healthcare administration, degree, which is great. But if you've never coded
Mm-hmm.
professionally, if you have never dealt with the intricacies of appeals and denials and understanding each payer, please, please, I'm getting on my soapbox here. Don't go to your team and act like you know what they're talking about when you don't. You've never walked in their shoes. You know how to manage them and to make sure things get done. You look at reports and you can tell from those reports where things are at, where your team needs assistance, where they're being less productive or more productive. But if you're just shouting out orders, get this done, and you don't understand the process, like in oncology, for
Mm-hmm.
instance, I'm so tired of people pushing charges out without waiting for the path report. I mean, that's a 100% like oncology 101, or anything in dermatology. Like, even
Mm-hmm.
you don't just submit claims without waiting for documentation. Maybe you have 15 claims that can go out that day. Maybe you have 5 or so that need to be worked on. Do you feel that it's worth it to you to just get them all out there? Or can you wait financially? You have 10 claims going out, 15 going out, but maybe 5 need some work. You're still going to have revenue coming in. It's not going to hurt your bottom line, maybe, for those 15 claims to go through that are right. Let your teams tell you, these are wrong right now. I have to fix them first, and then I'll put them out there.
It's funny, Jennifer, I teach a lot, and I always tell my students, coding is a science.
It is.
Coding is reading the documentation that's been provided and applying the code that best describes and defines that documentation. So it's either there or it's not there. So it's a science.
Yeah.
But billing is an art
Yes,
because you
it
have
is.
different payers, different modifiers for those payers, different policies, different indications, different limitations. What works for Medicare won't work for Aetna. What works for Humana won't work at Medicaid. Like, such an art of knowing that fine finesse of how to assemble that together to paint the perfect picture, like my friend Sonal Patel says all the time, right? And I think practice administrators need to understand those people in their practice. They've got their scientists, their coders, and they've got their artists, their billers, who are just trying to merge these two worlds together for perfection, right?
Mm-hmm. Exactly. And I just had to show Betty's comment because I dealt with this issue several years ago, and I would have coders or those that want to be coders come to me, and they would ask me about the difference between different credentials. And so I would tell them. And so they asked me about HEMA credentials. And so I laid it all out for them. This is what each credential is. And they mentioned the RH ones. And I said, I don't teach that. It doesn't have anything to do with coding. It's a completely different concept. You want to be a coder, get your CCS. I even tell them, if you want to be on the Profi side, get your CCSP. If you want to be a HEMA, if you want to be AAPC, that's a CPC. I will lay them all out for you. I will tell you which organization holds that credential, what they do, what your goal should be, what you're going to be doing in that job, so because you may have a goal in mind, and this credential is not going to get you there. So it's a really good point. You need to focus on your degree concentration. So what do you want to concentrate on? That is what you should know. And so I thank you, Betty, for bringing that out, because it's a huge world of difference between just coders and what they know and what they don't know and what they're focusing on.
Absolutely.
Lastly, I know we spend a little bit of time here, and I don't want to take everyone's time too much today, but we do want to focus on a couple other things. I want to talk about measuring progress, because we've done so much work, over the years to try to change things, and we want to see how well we're doing. So maybe we're working in a facility and we've had a whole year of data that we can look at. We want to identify what has been good about it. Where's room for improvement? Earlier, someone mentioned benchmarking. So what's the importance of benchmarking? Like, what do you think, Christine?
Well, I think that that's going to show you where you have areas that you're excelling in, and you have
Mhm.
areas that maybe require a little bit more assistance at that time.
Yes.
Um, I always love it when we're excelling. I love to see the reports come in where it shows that the changes that we've been making in the practice are working, and we're
Yes.
seeing the flow and the function really, really be supported. But again, in the other sense of it, benchmarking is going to show you: do you have a provider that maybe is an outlier that needs more attention? Is there a payer that is maybe not paying you at the negotiated rate properly, or maybe you didn't renew or reapply for that payer and you're not getting payments?
Yes.
Um, there's so many things that we can find out by reviewing those reports, by looking at benchmarks, by seeing what is standard. One of the reports that I think is often overlooked is the comparative billing report.
Hmm.
I know that Sono Patel is going to be doing an entire segment on the comparative billing report at the Business of Medicine retreat coming up next
Yes.
month.
Yes. Absolutely.
And I always encourage my clients, at least find out where you stand in your community amongst your peers. Are you seeing a higher level of 99214 patients? Are you doing maybe more procedures in one area than others? And not that that's a bad thing, because there are some doctors that specialize in certain techniques, in certain procedures that other ones in the same specialty maybe don't. But to know where you stand.
Exactly. It's important. And as the support staff, when you have support from your supervisor, when you see these reports, they bring them to your attention, and it kind of shows you where you may have fallen short in some areas with modifier usage, or maybe even the ability to apply the primary diagnosis correctly that drives reimbursement. You can
Mm-hmm.
see those results. Take that with a grain of salt. And managers, the way you present that information has a huge impact on how it's received and accepted and followed through with your staff. So think about both parties, how you react to that kind of scrutiny. But also think about how to, if you're a supervisor or a manager, whether it's mid-level, high-level, administrator, whatever it is, you have people under you, and you also have people you report to. So think about the feelings that you would feel if you were in that position, and always be thinking about that. You and I are going to be talking about revenue integrity at the upcoming NAMUS conference in Charleston in December.
So
I'm super excited.
excited.
It's a two-part session, and so Christine and I are going to tag team it, and we're really excited. Recently, I've gotten on TikTok, my first TikTok yesterday. I'm going to be
Yay,
getting on
I
there
saw
more.
that. That was awesome, Jennifer.
Thank you. Talking about revenue integrity, because revenue integrity starts with your integrity as a person. So think about the integrity you hold as a person, how you bring that out into your work life, and everything will show that, because you care about the data you're putting out there. So
Well, I
that's
saw
my
recently on one of Betty's Friday Fraudsters where a biller was actually found guilty because the biller knew what they were doing was incorrect, but they were being told to do it by their employer. I don't know about you, but that never worked in my defense when I was a child. Well, nobody else did their homework, so why would I do my homework?
yeah, right?
It didn't work then. It's still not going to work today to say I knew it was wrong, but somebody told me to do it or everybody else was doing it. Well, and I've heard providers say everybody bills for that, Christine.
Okay,
Doesn't make it
so
right, does it?
it does not. And recently I had someone tell me that there is, talk out there. Some facilities think that denial percentage of so much is completely acceptable. So they're okay with it. They're okay with this percentage of denials because they expect it. Like,
Wait a minute, wait a
well,
minute, wait a minute.
I
I
don't
I
understand
once
that.
was told that skimming a little bit off the top was still wrong. And I'm just going to say that a little bit wrong is still wrong, whether it's a little or a
Right?
lot. There is, in my opinion, again, of course, errors are going to happen, but I was always told when an error happens, you admit to the error and you fix the error. If Oh, here's a great example. So, my husband's an AC guy here in South Florida, and he was with this nice little elderly couple, and he told them how much it was going to be to fix this air conditioner for them, and they misunderstood him, and they paid him $100 more than what the bill was. And immediately he turned around and went up to the house and he said, I'm terribly sorry. Maybe I wasn't very clear to you, but it was this amount and you paid me $100 more. So of course they were happy to get that money back. And do you know that everybody on the block uses my husband now? That anything
Yeah.
that goes wrong with their family members use my husband now because the integrity is there. And we should be no different in healthcare.
Even more so in healthcare.
That's what I'm saying. Like
Lives
healthcare.
at stake.
If we were paid too much, we return it.
Yeah.
If we were not entitled to it, we return it, right?
Yes.
To the rightful persons that paid that money. So that one I could talk about all day long. You know, I can't wait till we meet in Charleston in December for NAMUS, because I really feel that we need to remind people that our own personal integrities should never waver, not for an employer, not for our personal gains. That personal integrity is what we should strive for, especially in this industry.
Yes, because nobody can take that away from you. That's the one thing nobody can take away. They can take away your paycheck by firing you, maybe, or letting you go. They can take that away. They cannot take away your integrity. So that's on you. That's your personal integrity. So I want to stress that enough. And there's compliance issues when you knowingly submit claims to be faulty because you just want to test the system.
Oh, wait, you mean we just can't put down diabetes for all patients because that's what gets paid?
Yeah, just put down E1140 for every patient, even if they don't have that condition. And I'm just like, really? And we're past the days of letting it slide with unspecified diagnoses in the primary position. We can go on and on, but
yeah, because I still get unspecified knee replacement.
I love it. I don't
understand.
understand.
Your hand. How is that possible?
Did you look at which side of the body you were working on? I mean, I know you at one point took an X-ray and you had to document, that you definitely know what side it was before, but for somehow today you forgot.
Now, here's my thought behind that too. I've been in this industry long enough to know that when we made the change from ICD-9 to ICD-10, a lot of providers said, we need some sort of a mapping. You need to kind of handhold us from what we know in 9, because we've had it forever, since the 70s. You need to handhold us over into 10, because we don't have time to stop and take all these classes and learn all these things. We need to continue treating patients. So I get that initially there was that GEMS mapping, the general equivalency mapping. However, I think as administrative staff, management staff, support staff, your coders, your billers, at this point, we need to take those providers onto that next phase where we're no longer using the GEMS mapping, but now we're telling them that the knee pain could be left, right, bilateral, or unspecified. And since you have it in your hand, just tell us what it is. And one more thing, I think that ICD-10 guidelines a couple of years ago, they realized that as coders, we know how to read left and right. We can add laterality to it. It would just be helpful if we helped our providers to permanently make that switch over to left and right. Does that make sense?
Absolutely. And, you and I are going to be at the Healthcare Advocate Summit next week in New Orleans. My presentation is going to be on, does your technology work for you? It's going to be really discussing the technology landscape we're in, and the EMR systems have created a huge burden for physicians where it makes it a lot easier for them to click a button and move on without checking the laterality. So we know they know, but they choose a code from the code picker that's in the system. And because coders are not involved, because facilities say, no, the physicians are going to code this, That gets on the claim. The coders don't catch it till it comes back. Then they see, okay, it's unspecified. That should be fixed. So the EMRs have a huge responsibility to make sure that they're making this process easier. If they're supposed to be claiming they're saving a practice money because their software does this, this, and this, well, guess what? It doesn't, because it's not getting the claims out correct.
It's a tool, Jennifer. It's a tool
That's all it
like
is.
anything else. It's just like your paper templates were. So 10 years ago, when you were on a paper template, it didn't mean that you were limited to the treatment that was available to document on the template. The EMR is the same. It is a template. It is there to facilitate ease of documentation, not to replace pertinent documentation that is necessary to either really tell that coder what you did, right? Or to tell a payer what you did, or even worse, God forbid, you were in some sort of a litigious action where they blow up your note to the size of a poster board, or they put it on the large screen in a courtroom and they ask, can you please walk me through this note that is 16 pages long and is yet to tell me what you did for this patient, right?
Yeah. It's a burden on them, but it doesn't have to be. Like, it can be simpler. So contact me at Healthcare Inspired LLC, because we are offering optimization for your EMR systems.
Oh,
We
nice.
know sometimes that it just takes a little bit of tweaking here and there for your specialty to get things right. So if you have a system where it doesn't make it easy for you to enter all of your NCCI rules and edits and hard stops, we can take care of that for you, because it's such a need. It will simplify your billing process so much if you set things up right the first time.
Tweaking the tool.
Tweaking
You
the
tweak
tool.
the tool. I
Tweak the
love it.
tool. I love it. Yeah. So contact Healthcare Inspired for that. Thank you, Christine, for coming on today. It was a pleasure as always. I look forward to
Thank you.
seeing you next week in NOLA. So it's going to be a blast.
Are we having
Um,
dinner at the gumbo shop again?
It sounds doable. Absolutely. So I have my best friend Autumn coming with me. We're going to I'm going to introduce her to the world that is Healthcare Advocate Summit. She's a pharmacy tech.
Yay!
And so I'm excited to introduce her to her people. So it's going to be a blast, and we're going to have so much fun. So we'll see you then. Thank you everyone for jumping on today, and join us next week for another live on TikTok right from the Healthcare Advocate Summit. I'm going to be live interviewing Christine and others, so stay tuned for that. We will see you guys next time. Have a great week.